This is actually from the Ileo-caecal valve, and the biopsy taken from the Ileo-caecal valve. Here we are seeing a lot of strips of Ileo-caecal sort of mucosa, and in this power view, I don't see much abnormality here. I'm seeing adipose tissues in the subepithelial area. This could be abnormal. Um, Sometimes it depends on the clinical findings. Much adipose tissues in the subepithelial, in the submucosa area. Is there any significant lesions apart from this submucosa lesion? I don't know. But in this hyper view, a little bit of hyper view, we are seeing the cribs, which are not very sort of normal, not very normal. Some of the crib extend to the lateral. Maybe some kind of serratia are present in the superficial portion of the crib, and the basal portion of the crib extend to the laterally. So this is serratia of the cribs, and there is also basal portion of the crib also included in the in serratia kind of things. So this is also serratia. What I'm thinking now is this serrated lesion? Because of the location, which is the right side of colon, sustained serrated lesions are very common in right side of colon. And another differential diagnosis is hyperplastic polyp, which is more common in the left side of colon. So, for the definition of the sustained serrated lesions, you need at least one undisputed crypt, which is highly compatible with the sustained serrated lesion. And I think we are seeing more than one crypt, which is fully compatible with sustained serrated lesion. So what is the big deal about sustained serrated lesion? It's actually a precursor lesion for the colorectal adenocarcinoma, which usually follows the path of CIPG or CPG island methylated phenotype CIPG. It is actually the hypermethylation process that occurs in the promoter region of MLH1, and is usually associated with the microsatellite instability, high colorectal adenocarcinoma. It can sometimes be associated with dysplasia, which may be adenomatous dysplasia, and it can also be other kind of dysplasias, so-called serrated dysplasia, and so on. So in this case, I don't see adenomatous dysplasia or other sort of dysplasias. And I think this is compatible with the sustained serrated lesion. See this crypt and this crypt, there are much dysplasias up to the base of the crypt, as well as there are some expansion of the crypt to the periphery. See this kind of expansion is compatible with the sustained serrated lesion. So let's write sustained serrated lesion, and let's check the answer whether it is correct or not. So this is correct, sustained serrated adenoma. The new WHO updated classification suggests the name as sustained serrated lesion. So it is basically the same. I think there is another thing, and another stain, immunohistochemical stain, which is Can67 in this case. And uh, so the purpose of Can67 is to highlight the fact that some or both sides, one side of the crypt, such as this one, has more increased number of proliferative cells than the other side. Here in this example, we are seeing much increased number of proliferative cells on this side, and on the other side it is not symmetrically proliferative. Yeah, some crypts are more proliferative than other crypts, and they are not symmetric, necessarily symmetric. And yeah, in this example, there are increased number of proliferative cases, 7 positive cells, and the other side is less positive cells exist. It can even highlight the lateral expansion of the crypt. So the big deal about the societal deletions is, because there is not much very visible confusional kind of dysplasias identified, you may miss the lesion as the benign, and it can lead to the is a patient safety issue, which is not a good diagnosis, which is not a correct diagnosis. Actually, this kind of societal relation is very important to recognize, because it is a precursor for the subsequent cancer. Thank you very much.